Good evening, everyone. It is so good to see you all here and gathered for this courageous conversation. I think this one is courageous because it's something that is hard to talk about, but we all know we need to, but tend to shy away from it. And so tonight, our hope is to give you some conversation starters, to give you some resources, and hopefully so I know from some of you, this conversation is one you've already begun, and hopefully will continue, and maybe some more questions to think about. You may be here because you are thinking about aging for yourself. It may be that you are caring for someone, for aging parents or a spouse, but we know that we will one day die, and we know that we are all aging. And we know that there are conversations and decisions that we need to make, and it's better to make while we can still make them. One of my best friends from childhood died of leukemia this summer, and so no one is too young to have this conversation. So I hope that you are here ready to think. I hope it will be challenging. But hopefully you'll leave with some information. When we selected today's date, I just said, okay, November 1st, that works in the church calendar. And then I went back and said, it's All Saints Day. How perfect a day to be gathered to talk about end-of-life care when we are remembering the cloud of witnesses in our own life, all those who have gone before us and taught us and loved us. But the cloud of witnesses also includes those who we are teaching and loving. So all saints, as you can go back and listen to Allison's sermon yesterday, we are imperfect saints, but thinking about that as we gather today. And so sharing a little bit of time of reflection. This is Paul in Romans chapter 14, verses 7 through 9. For we do not live to ourselves, and we do not die to ourselves. If we live to the Lord. And if we die to the Lord. So then whether we live or whether we die, we are the Lord's. For to this end Christ died and lived again, so that he might be Lord of both the dead and the living. This is the word of the Lord. As I light this candle, think of the cloud of witnesses in your life. All those who you are desperately missing today. Those whom you love dearly and want them to know that you love them too. And remember, and let us pray. This is a prayer that I use at many memorial services, and it touches me every time, and I thought was perfect for today. So let us pray. O God, who gave us birth, you are ever more ready to hear than we are to pray. You know our needs before we ask, and our ignorance in asking. Show us now your grace, that as we face the mystery of death, we may see the light of eternity. Speak to us once more your solemn message of life and of death. Help us to live as those who are prepared to die. And when our days here are ended, enable us to die as those who go forth to live, so that living or dying, our life may be in Jesus Christ, our risen Lord. Amen. So what brought you here tonight? I gave you time to think about it. It was on the screen. What brought you here to have a conversation?
Am I ready?
Am I ready? Mm-hmm.
Concerning.
Concern, yeah.
I planned my memorial service and I wondered who to give it to.
Joby's reaching out his hand.
You bring with you?
No.
Although people do that.
To just be sure I've covered all the bases that I think I've covered.
That's good. Well, there are so many different reasons. And I've invited Larry Dagwalt. Is that how you pronounce your last name? Good. I forgot to ask. And he is the Senior Director of Spiritual and Grief Care Services for Hospice and Palliative Care in the Charlotte region. He has been in hospice since 1993 and has been at hospice and palliative care since 1997. As a speaker, Larry has addressed national, regional, and local organizations on topics dealing with spirituality, comparative religion, compassionate communication, end-of-life care, and grief. He lives here in Charlotte and is the father of a son and 2 daughters and the grandfather of 5. So we are glad to have Larry here. I wanted to have him here because I work with so many families who have hospice care and are so deeply grateful, but so many others who hear the word hospice and hear a death sentence. And so I wanted Larry to come and share all that they do and all what resources they can provide and so many other things. So thank you, Larry. We have a big height difference. John has to fix it.
That's plenty. Thank you. Okay, can you hear me okay? As it wouldn't be a surprise to people who know me, I've been talking too much today, so I don't have a lot of voice left. But if you can't hear me, just say, speak up, and I'll talk a little louder. This is a beautiful room, and I just now found out what I like about it the most. It's got a clock. Doesn't mean I'm going to look at it, but it's got a clock. That's pretty nice. They thought of everything. Do they have clocks everywhere, like everywhere you'll walk?
I don't look at them either.
Okay, there you go. About a month ago, I was reading a book, and there was a paragraph that jumped out at me like one hasn't in a long time. It was written by a Eastern monk who was reflecting on his time in America. And he said, one thing about Americans I don't understand is they see people getting sick all around them. They see people dying all around them. And yet they think it's not going to happen to them. Well, it's going to happen. And we're going to talk a little bit about some of the end-of-life care that is available. First thing I want to talk about is something called 5 remembrances. The first one is you're going to get old. Now, I run a children's grief camp at Hospice and Palliative Care Charlotte region. You might have heard of it, called Chameleon's Journey. And the grief camp it started in 2000. And so we were packing up for the camp 2 weeks ago, and there were these pictures, or there are these pictures in our grief office area, and several of them are of me the first couple of years. And some new staff member said, "Oh, this would be wonderful to take these pictures out." Well, these pictures are 23 years and pounds ago. And so I made the executive decision that we were not going to take them. But you're going to get old. Number 2, we're going to get sick. Illness happens. Number 3, we're going to die. Number 4, everything we love and treasure is going to be gone one day. I hate that one, but it's true. And then the last one is what we have left are the relationships that we left and the good things that we've done. You probably heard people say, well, you can't take it with you. Well, you can, but you can sure leave it behind. And so what we're going to talk about tonight is maybe just a couple ways you can leave something behind that's good for your family, good for those who are surviving you, and good for yourself to know you've done it. Tell me your name.
Pat Craig,
Pat?
Craig.
We were talking, you need to let her show you some things that she has as a surprise that she's done for her kids, some things that she has left. But what happens at the end, in my mind, is not nearly as important as what happens day after day. And that's why it's great that you're here, talking to each other, sharing, laughing, eating. I have some good cooks in this church. My goodness gracious, does somebody run a bakery or catering service or something? That pumpkin thing you had, that was first class right there. You goes, who made that? Roll that up twice. And your shop has how many locations now? Just one. And I bet it's not public either, is it? I started at Hospice and Palliative Care Charlotte Region in 1997. I was the 120th person hired. I came from Gaston Hospice. I started there in 1993. At the time, we had a census of about 190. I was number 120 hired. We had a budget of $6 million. That was in 1997. We thought we were a big hospice. Today, we have 700 employees. We have a total census in our 32 county coverage area of about 1,200 now. That's just in hospice. Palliative care is even more so. So we're one of the bigger hospices, but our challenge is to do hospice like we did when we used to. Taking care of people in a way where they're not numbers, but they're names. And that's the way that hospice care was designed to be. Hospice care started in England. It came to the United States in the early 1970s. It came to Charlotte in 1978. When I say hospice, I am saying a specific word that has a definition. Hospice is a form of care at the end of life that is defined by Medicare and Medicaid as a health care service that is provided to someone who, in the opinion of a physician, has 6 months or less to live and is not seeking curative measures. Got these brochures, they're over there if you want one before you leave. So 6 months or less, and the smart aleck question immediately is, well, what if they live longer than 6 months? Well, you keep getting recertified. The physician has to go through your record again. But during that time, there is a team that provides care that is made up of a physician, nurses, social workers, volunteers, nursing assistants, chaplains, and then grief counselors. So my area is, I'm over the chaplains and grief counselors. We have about 18 chaplains now. And I think there's 12, 13 different grief counselors. But what hospice care provides, the overall name of that is palliative care, which is symptom management and pain control. But when we say palliative care per se, as far as palliative medicine, that's for people who aren't quite there at the 6 month point, but who need medication management and symptom control because they have a chronic disease, and more than likely they're headed that way more than some other folks. So the palliative care program is designed so you don't get all of the hospice services, but you get maybe twice a month, maybe even once a month, you get some sort of consultation as to what might be going on and what you need to be prepared for. So when we talk about end-of-life care, we're talking about care to people that are perhaps in many ways exhausted from what they've been through. it's really sad in my mind as I look back on what people have gone through just to get to us. And by the time they get to us, it's generally thought that they accept that they have 6 months or less to live. Some people still don't accept it. And it's hard for some people to say, well, we don't want hospice because that means mom's going to die. Well, unfortunately, mom's probably going to die whether you accept the care or not. When I started at Gaston Hospice, early, mid-90s, we still had people that didn't want us to tell their mother that she was under hospice care. And so you'd take your badge and you'd either do it this way or you put it inside so mom wouldn't know she had hospice. And my way of answering that is, yeah, mom knows she's going to die, and she also knows where you were that night at the prom, and you just need to back off and let mom be mom. But the acknowledgement is such that at that point, we start thinking in a different way. And for one thing, one of the joys of hospice that I've seen happen over and over is hospice gives people an opportunity to let go. We fight and fight and fight. And sometimes we're fighting for a quality of life that certainly is not what it used to be. And so for me, good end-of-life care has to do with giving people an opportunity to talk and to communicate, especially in terms of reconciliation, having good relationships, saying what they want to say. But you don't have to be under hospice care to do that, which is why your courageous minister has said, we're going to have some courageous conversations tonight. And please don't just leave these around the table. I was in years ago on the end-of-life care movement in North Carolina State Hospice Association. And we developed a campaign called Isn't It Time We Talk? And Isn't It Time We Talk was designed for people to have courageous conversations around Thanksgiving. That, we gather together to have courageous conversations. That's hymn 424 in your hymn book. We gather to, and the idea was that since everybody's together, this would be a good time to do it. Well, it didn't go over very well because people said, I don't want to ruin our Thanksgiving. But at the same time, what it brought about was some of the questions that are raised that you have, that you talk about these rather than talk about the Panthers or other depressing subjects. That you get in a situation where you talk about something real. And the best time to do this is when you're healthy and when you're of sound mind. And you can honestly say, this is what I want. This is what I don't want. I don't want this. I don't want this. I don't want this. Now, let's talk just a minute about the medical profession. Any nurses, doctors? Okay. Physician? Okay. In my background, as far as training goes, physicians are taught to treat. And physicians, unless they're a hospice physician, and I can hook you up if you'd like to change from whatever you're doing to hospice care, I can hook you up in a hurry. But physicians don't have the time that they used to have. And so the idea of sitting down and talking with your physician for a long period of time, unless you're married to him or her, that's going to be tough in this day and time. And it's tough on them because they would like to have conversations that they can't do anymore. But one of the greatest gifts you can give to your physician is to have had the conversations already and say, this is what I'm thinking about. I'd like to get your input. I want to lay this out for you. This is what I'm thinking about. Let's talk about this. Because nobody comes under hospice care without the certification of a physician. We have our share on board, but ideally, your attending physician is the person that's going to say, we have had these conversations based upon my examination and where this disease process is. I believe it's time for your team to come in. And once that happens, if that conversation has been had, the physician continues to follow. They follow basically by communication with our team, but they have an opportunity to follow their patient through that process. Now, once you get under hospice care, ideally you have somebody called a primary caregiver. And that's what Cicely Saunders, the founder of the hospice movement, that's what she had in mind when she started hospice, because basically what she was seeing there at St. Christopher's in London, she was seeing people who were pushed up to a higher floor, they were pushed down to a corner ward, and they were basically being ignored not only by family, but by the medical team as well, because there was nothing we could do. Well, looking somebody in the eyes, holding their hand, putting a damp cloth over their forehead and saying, "I love you," is something you can do. It's valuable care. And the National Hospice and Palliative Care Consensus on Palliative Care has defined spirituality with a key word that applies in 5 ways, and that key word is connection. And one of the greatest gifts you can give to somebody under hospice care and really at end of life is connection. Think what a great gift you've given each other tonight, just to connect. You know, I saw some of you come in, you looked and saw somebody and you just, "Oh, you're here, nice to see you." I think I might have saw a post-COVID hug or two, which is really nice when you consider how deprived we've been of hugs for the last 30 months. But being in a situation where you have connection is part of what hospice is. That there is a team, you know somebody's going to come by, somebody's going to check on you, and there's going to be a chaplain and a social worker that's going to be encouraging over and over other family members to do the same. We talk often about what a good death is. There's also an antithesis, and the antithesis for me of a good death is a death where somebody dies alone. I'm going to try to say this, but some of the saddest moments that I've had working in hospice care have been when a family or a family member took a relative up to the hospice house and dropped them off and drove away. And that's the last time they saw that family member. So if you have connection, utilize it and keep your connections open. If you want to make sure your children are by your side, do your best to forgive them, especially if they don't deserve it, because they're going to wish that you did. And as a grief counselor, one of the things that I try to communicate the most is when I'm talking to people in my office, rarely are they troubled by the things they said. They're troubled by the things they did not say. And so having those conversations are very important. What diseases are eligible for hospice care? Any life-limiting disease. Now, when I first came on board, it was cancer. It was mostly cancer. Now, believe it or not, less than 50% of our census is made up of cancer patients. The fastest growing diagnosis is, of course, dementia. But dementia is hard for a physician to diagnose because the basic definition of hospice says, should this disease take its traditional course? And dementia don't have no traditional course. Could be 10 days, it could be 10 years. How many of you done dementia caregiving? Thank you. I just want to say thank you. That's all. Thank you. So when we're talking about end of life, we're talking about various diseases, various diagnoses. But the unifying thing is that there is a team led by physicians that meets at least every 2 weeks to talk about what's going on. There's also something in the United States called the Hospice Medicare benefit, which means if you're on Medicare, at the time you come under hospice care, everything's switched over. So it's paid for by hospice, which is pretty nice. At the same time, there's not any treatment in that that's moving toward resolution of the disease process. but it is comfort. And people often ask about medications because there are evidently some horror stories out there about how much medication we use. And I'll define it this way, and as a physician, you might can help me with this, but the way we define it is our doctors are doing, and the nurse practitioners as well, they're doing their best to have the pain medication meet the disease where it is. And so you don't want too little, you don't want too much, but you want them to meet in such a way that there's a comfort level where people can still talk and communicate, if at all possible. We have hospice houses. Ours are called the Levine and Dixon Hospice Houses. Thank you for shopping at Family Dollar, and thank you for shopping at Harris Teeter, because these generous people have combined their money together 3 different times to build hospice houses for us in Huntersville, at Aldersgate, and over at Southminster. These are beds that are for people who would otherwise have been in the hospital, but they have to have what we call a GIP, a general inpatient diagnosis. So they're very sick, but sometimes they come in just to have what the GIP is for, such as pain, dyspnea, and then they maybe go home. The majority of the patients that go there do die. How many of you have been in one of our hospice houses? You know where they are? Yeah. And these places are really wonderful because they give an opportunity for families to be together. The one up at Huntersville looks like a ski lodge. It's pretty. You been?
Mm-hmm.
Yeah. Yeah, it's pretty. That was designed by a person who served our company over 20 years as director. Her name is Janet Fortner. And she designed that. She loves craftsman style. And it was really ironic that she got rewarded for all her hard work. That's when her mother died. And so there was a circle there. There was a payback. We're in South Carolina now. Like I said, 32 counties. We're kind of everywhere. But one thing that we're here for as much as anything else is for education and to clarify things for people so that you'll perhaps understand. So the clock that I just looked at says it's time for me to move to questions and hopefully answer. So what questions do you have? What did you come expecting me to talk about that I haven't talked about yet? Yes.
My question is, how can I be sure that I can have control of myself and that my children don't take over and make the decisions for me? What can I do legally or whatever? What's the
How many
step?
children do you have?
I have 2, and they're trying to treat me like I'm the child.
The first thing I would do is paddle them. They need a good whooping. They probably had one left over that they didn't get. There are documents that can be signed, and these 2 are talked about with a physician. I just updated mine, but there are documents that can be signed. Also, there's something called a healthcare power of attorney, and hopefully you can find somebody that you can trust to do what you want. The best person to have the conversation with initially is a physician, but you can have a healthcare power of attorney. You can have your end-of-life care documents signed and just notarized. You don't have to have an attorney do that. But some of the questions that you guys are going to go through are part of a end-of-life care document, and I would recommend that you go over that, and perhaps you want to talk to somebody, a chaplain or a social worker, even in our organization, as to what specifically you can do. But there are documents out there. Does that help?
I guess so, because I've done some of it, like I have the financial
Right.
power of attorney, and they know that I don't want to have prolonged life if there's something, to
Uh-huh.
not put me on, but I want to be able, it came up when my husband died.
Yeah.
The 3 of us were on 3 different,
Uh-huh. You and the 2 children.
2 boys.
Uh-huh.
My husband had a cardiac arrest, and they revived him, and they took him to the hospital. One son said, "Mother, he's not gonna make it, there's no reason for having him being put on all these wires and stuff."
Right.
He wanted to go through a protocol, which was like about, 24 or 48 hours to check to see if he could have, if they,
Right,
be completely revived and not be brain dead and stuff.
Sure.
The other son would even had the nerve to say, "Mother, you're just costing our federal government money because he's on Medicare. He's not gonna make it." And the nurse told me later, she said, "You made the right decision
Yeah.
saying you wanted the protocol because now you know for sure that he was not gonna make it."
right. Yeah,
But
you need
But that was a difference, and so I realize now that that's the kind of thing I'm talking about.
there's something called a MOST form, which is actually a physician order that you can have signed. Also, is there one of them you trust more than the other?
They work as a team.
You should have paddled both of them. I'm sorry, under that circumstance. But I would fill those documents out, and I would talk with your physician about what a MOST, M-O-S-T, what a MOST form is, because that is a physician order that you can have signed.
So that the physician makes the decision and not them.
Well, you and the physician have made the decision together.
That's what I want.
Yeah, you have made the decision together. And in the 7 minutes you get with your doctor, if you take 5 of it doing that, you've had a good visit.
And that way they can't say, "Well, we're not going through the protocol. You're dead, Mother."
Hopefully. But I could stand up here a long time and tell stories about families at the end of life. And does anybody have somebody a relative in California that would be flying in? For some reason, we always have trouble when people fly in from California. The folks around here are fine, but you get somebody that flies in from California, somehow or another, they know it all. They know everything. They know more than I know after the 29 years. Okay, that's my rant about California. And I love the place, and I go tomorrow, but I come back in 4 or 5 days. What are the questions?
Who is on a hospice care team? Can you describe all
Uh-huh.
the individuals on that?
The hospice care team is called the IDG, the Interdisciplinary Group. And so the primary member, as far as visits in home, is a nurse, a registered nurse. But there's a physician on every care team. There's what we call a team manager, who is administratively over everyone. There are nursing assistants. We call them the angel ladies. They're the ones that take care of skin control. They make sure that a person is clean, is taken care of. Social workers, and social workers are for reconciliation, but social workers also to help get everything in place. Volunteers, we have about 400 volunteers. And the majority of them do what we call respite volunteering. Any volunteers here for our organization? Run into them a lot. But they give people a break. Our volunteer motto is like the old McDonald's commercial, "You deserve a break today." If you can give somebody 2 hours, a caregiver 2 hours, you've done an amazing thing for them. And then our chaplains are healthcare chaplains. They're really interfaith chaplains in terms of those of you who keep track of the Pew Research statistics know that religion is changing in our country. But if someone is of the Christian faith, very fortunate because all the chaplains that I have hired are originally of the Christian faith. But if there are people outside that, we work with Mecklenburg Ministries and other organizations to help people wherever they are. Our philosophy of spiritual care is we meet people where they are, we take them where they want to go. But it sure is nice when you meet people every now and then who know the same hymns that you know, and you can sing that old time religion makes me love everybody, and you can just see it in their eyes as to what's happening there. But that's basically the care team. And then of course there's financial and administrative support. We're fortunate we have real good leadership at the top. But the basic care team that you're going to see week after week is a nursing assistant, a chaplain, a social worker, and probably a volunteer. And then afterwards, there's that grief team I was talking about.
What's the difference in what you do with hospice palliative care and the palliative care process at the hospital itself?
Okay, that's a great question. The palliative care process at the hospital itself is sort of a pre-hospice as to where a person is. So they're going to be talking about scenarios that possibly could happen, but they're also going to be calling what they see right now. And they're in palliative care, what we call it is a consult. It's basically a consult in terms of determining as close as possible where a person is and what they need to follow, how they need to be followed. It turns into hospice when the disease process has moved to that point. But if you have an opportunity for a palliative care consult at a hospital, you definitely want to take it. Because at that point, you're going to be relating with somebody who's not necessarily going to send you to the next treatment, the next treatment, the next treatment. They're going to say, let's sit down and talk a little bit. Yes?
My sister's in Ohio, is under well, she thought it was Angel Lady. It's really Angel Care.
Yeah. Oh, okay.
Not always ladies, but it's a wonderful service. And
I'm glad.
they come twice a day? Yeah, twice a day. So
Oh, wow.
Really a good program. Just a comment, I don't mean to say this lightly. It's, what's the saying? Getting old is mandatory. Acting old is optional.
Yeah.
And the reason I say
I like that.
is
Yeah.
the reason I say that, I've been, I would say fortunate, it's unfortunate, had many friends that have passed in the last 5-10 years, and visiting them in assisted living, hospice situation, is not, as you know, is not always easy.
Yeah.
But you made a comment about some people just being dropped off.
Mm-hmm.
That's the last time you see them. Although that's sad, what's sadder to me is, I know there's one particular one in Pineville where my good friend was in the one wing and he was lucid and all.
Mm-hmm.
But the other wing, so sad, people are sitting in wheelchairs,
Yeah.
just not knowing where they are or anything, just, and I don't care who would visit them, they don't
Yeah, they don't know.
recognize anything, and
Yeah.
that's a sad thing about all this hospice care. I mean, that's gotta be, to me, one of the biggest problems in your profession.
The memory care. Yeah.
It's
It
so
is.
sad, it's,
Yeah.
even my sister who is lucid says, they gave her till July and she's still going strong.
Mm-hmm.
She can't do anything, but, she said, I just wish to get it over with.
Yeah.
And she recognized that being sound of mind, but these other people it's, any other thoughts on that, what to do with those people?
I would be a richer man than I am right now if I could figure it out.
Yeah,
What I tell our chaplains is you try to meet the person where they are, even if they don't know who you are. So when I'm doing a call on a person in a wheelchair that doesn't have memory, first thing I try to do is get eye to eye with them. I don't want to get in their space totally because I don't want them jumping back and I don't want them getting scared. But I want them to get down as close as I can. And I want to find out what year it is to them, if they can communicate at all. If they can't communicate at all, and if I have no chance whatsoever, the only chance I'll take is if I can find their religious background, I'll try to find a song. Because when my grandmother died in 1993, she was at a memory care unit in High Point. She didn't know who she was. She didn't know who I was. She didn't know where she was, but she could mouth through a locked jaw all 5 verses of Joy to the World. And you could see her just sort of moving it there. Something about music, and it's a wonderful thing about Christianity, is we are a bunch of singers. And somehow or another, between feeling, between the auditory, between singing it itself, between the pictures that we make as we're singing, this gets neurologically embedded in us in such a way that I think it's one of the last things to go. And if you can find somebody, if you can find their song, that's where I go. But it's it's hard for me to overcome the sadness, and watching Mary Lee mouth at him is a gift that she gave to me and that God gave to us to know that that was deep in her soul, even as she was close to dying.
Not to digress, but one thing that I've learned is that I've had the honor of doing several eulogies. And I always try to end it by saying, pretty much along the same line you were talking about visiting people. Every day we think, oh, I haven't talked to this guy or this lady or this person in 6 weeks, 6 months, a year, whatever. And just, when you think about that, call.
Yeah,
Because that's the saddest thing is, you know,
yeah,
I just can't, it just breaks my heart when someone passes. I know I should have called them
Yeah.
last week or something like that, so if any of you have that thought, I encourage you to call the person that you think.
yeah, absolutely. Now, in our grief care, it's on Microsoft Outlook. You call people at certain times. And you might want to do that too. Write it down. I need, probably 3 months will be a good time. I'm gonna put it down now. Any other questions? Hi.
Hi. How do you choose hospice care? I mean, when you've been told that you can go in, do you choose the place, or does the place choose you by the availability of the rooms?
I'm sorry, I need to hear that a little more.
How do you, when you've been diagnosed to go into hospice care,
Uh-huh.
how do you choose hospice care? I mean, as in, do you choose, do you make the selection, or does the hospice care choose for you by the availability of the rooms?
Like which company you
Yes.
went with, sort of?
Okay, yeah, that's a great question. You'll be offered at the hospital, you'll be offered, hopefully, companies that include ours. But yeah, you choose which one you want. There are signed documents between you and that provider. Now, one thing that you don't have as much choice on that's more dependent upon the diagnosis itself is whether or not you go to a hospice house, because the majority of our care is provided in the homes. If a person can be taken care of at home, that's what we go for. Sometimes it's too much for whatever reason. It might be because of the way the disease is playing out. It might be medication management, and they really need to go there. But there are different companies now. It used to be hospice at Charlotte was the only game in town. There are many different companies, and you would talk with your physician about that. In most cases, a physician has a pretty good idea who they want to use, but some of it's based on experience. Who took care of somebody before, and what kind of job did they do? We have all these numbers, hundreds and hundreds of patients, but we're only as good as our next visit. We're only as good as the next person that we take care of. So quality is a real big thing in that regard. But yeah, that process usually takes about 3 days from the time you're diagnosed to you're actually admitted. But during that time, you're talking with our admissions team, a team that will hopefully outline things for you. And one of the big things you want to look for, which is a commercial for us, of course, but you want to look for what kind of on-call services they have. You want to make sure that you're dealing with a hospice that has 24/7, 365 on-call provided by hospice people. Because in the middle of the night, you want somebody that knows what they're doing. Yes?
When I hit that point where my wife should just put my backpack on me and push me down the trail, and I don't know where I am, what do I have to have in place for her to put me into hospice care?
It's like a wagon.
You have to have the communication between her and a physician that should your disease take its traditional course, you have 6 months or less to live.
But I don't have to commit to that point. If this, she has the power of, the power of attorney to do that.
Yeah,
But if that was not in place, who acts on my behalf? Spouse, children? They can do that without, because I can't input to it.
well, if you have, Yeah, if you have capacity, and you're in a position where you are of sound mind, yes, it's your decision. If not, hopefully provision has been made as to which person would make that decision. And there are, in the state of North Carolina, there are a specific tree as to who comes where, who comes when. But none of that will happen without the certification of a physician. And if you don't have a physician to do that, one of our physicians or nurse practitioners would do that for you.
Being of sound mind, you're supposed to question that today.
Okay. Well, I figured that, but I wanted to just lay it out there. But competency and compassion and capacity are two big words.
Okay.
Any other questions? Yes, sir.
A couple of just comments. Thanks for coming. So I was fortunate when I started my medical training about 23 years ago. My first month, I got to work in a palliative care unit in the hospital.
Oh, wow.
So one of my mentors, who I still to this day keep in touch with, is a palliative care hospice physician.
Okay.
So I was on the fence about 20 years ago about becoming a palliative care doctor or a cancer doctor. So
Okay.
I chose oncology, but I've always it's always been near and dear to my heart, the whole palliative care.
Yeah.
And so, part of my exit strategy when I get ready to retire may be to come over and be a hospice doctor maybe for a bit. So I may get in touch with you later about that.
Okay.
But,
He has my card and you'll have it before I leave. And I don't say that jokingly. I say that because I hear some passion.
yeah, but, I spent a month with him when I was a first-year resident, and we did home visits with the hospice patients.
Uh-huh.
I don't know, it was so moving to me. I'd love to be able to finish my career doing home visits again. I just
Yeah.
can't do it now. It's just not feasible.
Yeah.
The way it's set up. But I wanted to piggyback on what Bruce was asking earlier about the palliative care and the hospice in the hospital. So just, in my experience at least, most hospitals have palliative care services and hospice services both.
Right.
And then most areas, Charlotte included, have home hospice and home palliative care.
Right.
Not all places do, depending on how rural you get. But there's also palliative care clinics. So like, you guys have a clinic where patients that are ambulatory and able to go back and forth to their doctors can go to the palliative care doctor, and be seen there, just like they can see their general doctor or a cardiologist.
Yeah.
And get palliative care for years sometimes.
Right.
And it doesn't have to always lead into hospice. It oftentimes does dovetail from palliative care to hospice, but not always. Sometimes it's just a temporary need for some symptom management. So
Yeah.
there's really a lot there with the palliative care and the hospice to help people. And the other thing I'll just say too is that it really can be pretty simple. Like if a patient's in the office with the doctor and the patient or the family decide, I think we're ready for hospice, but we're just not sure, all it has to do is just have that comment. We can then refer the hospice, we call you guys up and say, can you go see Ms. Jones the next day or two?
Yeah.
You show up at her house, you tell them what you do, what you don't do, you explain it all, and they say, oh, now I understand, let's do it. Or I'm not quite ready, maybe I'll call you later. But that way it's not a whole lot of paperwork and discussion.
Yeah.
It can be very simple.
Informational visits. Yeah, our palliative care clinic is in one of our two little avenue buildings. A Bonefish Grill, you know what that is? Down south? I knew that, everybody knew that. Okay. Instead of the daycare, go to the next building, 7600 Little Avenue. And that's where our palliative care clinic is. And that's usually a medical conversation, but every now and then I get to talk to some of those people too, especially from a spiritual and anticipatory grief standpoint. There's another thing I want to point out real quick. When anticipatory grief, that's what you're going through when you have a loved one who is sick or dying. There's also something called preparatory grief. That's what the person themselves goes through. So don't ignore the grief of that person, because what they're hearing, what they're feeling, and some of the conversations that they want to share, they maybe haven't come out in a long time. They need to come out. Yeah, one more.
From my own experience, when my husband died, we had a son that was just going to be way on the other side of the globe. And I found out something, at least for Presbyterian Hospital. They will keep the body even for 30 days with no charge. If the funeral home takes it, they charge you $100 a night. So that's a nice thing to know. Secondly, after you've lost someone, one of the greatest things is this grief share. We don't have it at our church, but they do have it at the Christ of Lutheran, which is a great program for people who've lost a loved one. So it's a 15-week
Yeah, I'm familiar with that.
called Grief Share.
We follow people for 13 months, and about 20% of our survivors will receive grief care services, but more and more communities of faith are providing grief care, counseling services themselves. Stephen's ministry, I strongly advocate Stephen's ministry because it's that connectedness word again. Did I see one more, or are we done? Thank you, folks. Nice to be with you.
I think I got it. I have a few things to share if I hit the right. So we got to hospice, but now we are meeting you where you are today. And pull my book out. If you have not read Being Mortal, I highly recommend this book. It is a great perspective about how we live while we are dying. And I read this in 2018 while my father-in-law was in hospice care, and it helped think about what quality of life is. And this is part of this quote. It is not death that the very old tell me they fear. It is what happens short of death, losing their hearing, their memory, their best friends, their way of life. As Felix, one of this doctor's patients, put it to me, old age is this continuous series of losses. Philip Roth put it more bitterly in his novel Everyman. Old age is not a battle. Old age is a massacre. With luck and fastidiousness, eating well, exercising, keeping our blood pressure under control, getting medical help when we need it, people can often live and manage a very long time. But eventually the losses accumulate to the point where life's daily requirements become more than we can physically or mentally manage on our own. As fewer of us are struck dead out of the blue, most of us will spend significant periods of our life too reduced and debilitated to live independently. We do not like to think about this eventuality. As a result, most of us are unprepared for it. We rarely pay more than glancing attention to how we will live when we need help until it's too late to do much about it. I'm sure we can all share those stories. And that is one of the reasons I thought this was so important to talk about tonight, to know what resources are available, but also to start having these conversations now, when we are able to, when we are, those of us gathered here are of sound mind and ready to engage, even when we don't want to think about it. My grandparents were snowbirds and went from Ohio to Naples, Florida in the winter, and they stayed longer and longer in Naples. And when my grandpa was asked why he didn't come home more, he said, all my friends are in Sugar Grove Cemetery. And so I think that's, no matter what age we're starting to experience more losses. So thinking about how we want to live while we are dying is so important. And thinking about that, the first conversation we have to have is internally with ourselves, and part of that for me is with God. Like, what does life look like? What does a good day look like? And then we need to think about who we need to have that conversation with. Do we need to have that conversation with our aging parents, with a spouse, or with anyone else we are caring for, and your kids too? So I was thinking about these things and trying to come up with all these questions. So I love to research. I typed it in Google, and Google brought me to the Conversation Project, which is the handout on your table. For those of you on Zoom, it is in the chat, and you can Google Conversation Project and this will come up. And it's the stapled copy. This has some great questions and even some prompts of how to, this was more than I could have done on my own and much better researched. So this is a conversation guide for you to go through with family members and with yourself. And thinking, and Atul Gawande talks about this, what does a good day look like? For each of us, that's different. We may need to be able to eat a giant feast and to have good food. That may be a good day. A good day may be throwing a football in the backyard with your grandson. A good day may be trying to watch the Panthers win. But that will help determine, but I had to go with Larry's point, and not throwing your helmet in celebration. But a good day can determine the amount of care and medical assistance you need to live, and that may determine where you are. This goes through a lot of those questions. And so thinking about who you want to care for you, who you want to have those conversations with in the end, thinking about what matters to you in the end. The end could be next year. So thinking about these types of things are so important. For one that came up for me when I was doing, last year we said goodbye to a lot of people here at Sardis. And so I called my parents, they're divorced, and said, okay, I need you to tell me where you want to be buried, because I don't want to decide. And so those are some of those conversations that we need to think about. I'd meet with families that haven't decided, so like, do we want the columbarium? How do I get a plot? Some of those things that are, you can decide now. It could be you want your ashes sprinkled somewhere. Well, tell your people what you want. How do you want to be remembered? I love meeting with families and hearing about their memories and celebrations, but be thinking of those, what you want to share with your kids, with your family, of what are some of the proudest moments of your life? What are significant memories? They don't necessarily, if it's your kids, they don't know your childhood necessarily. So think about those stories you want to make sure they know. What conversations do you want to have with God? I think you may be having them already, but some of those conversations to start praying now. Of course, memorial service planning is something that is so sacred, and Joby and I both, we will talk to you when you're alive to plan your service. And we have funeral service planning booklets that give you a great guide if you want a guide for scripture, for hymns and music of suggestions that are used often. But think about that and give that gift to those who are planning your service. Maybe you just want a graveside service. Of course, funerals are for the living in honor of the dead. So your family might want to celebrate you with the organ playing rather than outside like you want. So, but having that conversation to explain, and that they can explain to you, no, Dad, I want to celebrate you with this hymn. I think that can be a beautiful conversation. So that is how you care for your grieving loved ones after your death. Because there will be grief. So how can you care for them while you're alive in making those preparations? So, we're right on time. So I do hope that you look at this conversation guide. You can find it online and think through these questions. We have resources in hospice and palliative care and lots of things. I hope you're leaving with more questions than answers, but questions that you will have conversations about to determine what those answers are while you still can. And know what you need more information about to ask, or to even think about. To say, well, I don't know what hymns I want, but I want this. We can talk to you about that. And Joby and Allison and I would love to pray with you about all of those things and care for you. We care for you a lot now. but continue caring as you wrestle with these difficult conversations. We do have a sheet on the table. Are they in the back? They're in the back, where we'd love to hear what your thoughts from tonight are. If you would fill those out. Chuck, this is for the stewardship impact forms. We're doing our work. We are trying as a church to capture how we do events. But I hope, yes, Alfred,
I'll put a plug in for one more thing.
of course.
5 Wishes, I think it might be 5wishes.org. But yeah, it's a wonderful website. It's a booklet you can get in print or online. I think it's free or maybe a few dollars, but it basically allows you to walk through, it has the forms like for healthcare, attorney, and the other forms, but it also has questions with plenty of room to write out how you want, like gives you a chance to write something to your kids or to your spouse or to other people, and what music you might want at your service, and you can list all kinds of things that you want people to know about your blank wishes in terms of the funeral service as well as before. It's a nice space to kind of create this document. You can then leave for you can review it with your family, or you can leave it for them, or whatever. So it's a 5wishes.org.
Thank you. That's good. Yes, Bruce?
I'm gonna put a plug in, Sardis is a student ministry congregation.
Mm-hmm.
And if you've never used a student minister, and you need to know more, we'll be glad to talk to you about what they can do. But you don't have to walk alone. There's somebody in this congregation to walk with you.
Definitely.
We'll be talking about trying to get some more Stephen ministers soon. And if you think you might be the kind of person who wants to walk with someone else, you'll have an opportunity.
I'm going to close with this blessing from Jan Richardson, who is a wonderful author. For those who walked with us, this is a prayer. For those who have gone ahead, this is a blessing. For those who touched and tended us, who lingered with us while they lived, this is a thanksgiving. For those who journey still with us in the shadows of awareness, in the crevices of memory, in the landscape of our dreams, this is a benediction. Amen. Thank you all for being here.